Well, hello and welcome to our webinar on developing a state pain guidance document. My name is Tammy Bauman with Great Plains Quality Innovation Network, and I am a Quality Improvement Advisor on our Medication Safety and Care Coordination teams. Great Plains QIN is the Quality Innovation Network Quality Improvement Organization for Kansas, Nebraska, North Dakota, and South Dakota, and we aim to achieve better health care, improved health, safer care, and lower costs. I'd like to welcome and thank our audience for participation today. We are very fortunate to have representation from a diverse mix of partners and stakeholders from our 4-state region. Today's webinar will be recorded and it will be posted to our website at greatplainsquin.org. It'll take approximately 7 to 10 business days to be able to access the recording. There will be an opportunity for questions after today's presentation, or you can post any questions during the presentation via the chat function on the bottom right side of the screen. Paula Sitzman will be monitoring the chat feature throughout today's WebEx session. Today's presentation, along with other upcoming webinars, focuses on the treatment of pain, one of the 5 pillars to address the opioid epidemic at a community level. Previous webinars discussed take-back programs and prescription drug monitoring programs, and recordings of the past webinars are available on the Great Plains QIN website. Now I'd like to introduce our speakers, Dr. John Massey and Amy Reynoldson. Dr. Massey is an anesthesiologist and pain management specialist in Lincoln, Nebraska. He graduated with honors from the University of Nebraska College of Medicine in 1990. He has more than 28 years of diverse experiences, especially in pain management and anesthesiology. Amy Reynoldson is the Prescription Drug Overdose Prevention Coordinator with the Department of Health and Human Services, Division of Public Health. Amy oversees the implementation of the CDC Prescription Drug Overdose Prevention for States grant, which includes the Prescription Drug Monitoring Program, development and implementation of statewide prescribing guidance document for opioids, and naloxone education. We thank Dr. Massey and Amy for taking the time to present today and for sharing both of their knowledge and expertise with us. I will now turn the presentation over to them. Dr. Massey.
Thank you, Tammy, and good afternoon, everybody. Happy to be able to present the work of our committee on the pain guidance document. We found it to be an exciting process and one that we believe is going to help guide clinicians to improve the care and reduce risk, improve safety in the state. So with that, let's move forward and go about presenting how we're going to recommend that people use the guidance document, how we can address the problems associated with opioids using what we've created here. Everybody attending this meeting understands the opioid epidemic and its role it's played in increasing mortality in the United States. The CDC has recognized this for a long period of time as a problem, and we all know they came out with guidelines a couple of years ago that have been a helpful response in initiating the process of moving towards safer and better care. 115 Americans die each day from this problem. We know this exceeds motor vehicle accidents, and we know that this has been increasing rapidly over the last couple of decades. The 3 waves of the opioid crisis, I think, are interesting, and they kind of inform our approach that we want to take. We all understand that beginning around 2000, we started to see the increase in deaths from opioid use. That purple chart diagram, or line there you see is the prescription opioids, and they're steadily climbing from 1999 to the present time. We understand that they've gone up 400%. And what we see with this area under that curve is a large volume of patients on opioids. Increasing every year annually and still increasing. We see in about 2010 there's a slight deflection in that upward curve as people became aware of the problem and began efforts to reduce the opioid use. Sadly, at that time, there were enough people who had become dependent, were opioid abusers, that they were finding other ways to access this molecule, and they first went to heroin, which is one of the illicit drugs, and it started its very rapid climb in the mortality literature at that time. And then a little bit later on, with a lag even further, were the synthetic opioids. Once again, we should understand these are being created illicitly By external labs, it's not the fentanyl-type products that are being prescribed as much as it's the very highly potent fentanyl, carfentanil, sufentanil, those kinds of agents that are basically adulterants to other medications, probably heroin, and used on the street. So right now we have a mixed problem with both prescription opioids and the illicit opioids leading to respiratory arrest and death. Let's go to the next slide. This slide, I think, is one that I like to use when we're talking about the different portions of the problem and the different ways that we want to address it. We need to understand that opioids have been used. They've been recommended for a very long period of time. Since the late 90s, we've been advocating for opioids for more benign pain conditions and chronic pain. We underestimated the risk associated with this, and at that time we were also overestimating the therapeutic benefit for chronic pain with the opioids. So we had a very large number of patients being prescribed these medications. A subset of these people, a subset of these people then developed problems with opioid abuse or opioid dependency, psychological dependency. So you see for every 825 non-medical users, these are people who are starting to use these medications in ways that are different than they had been prescribed or for ways that were additional to what they had initially been prescribed. And then a subset of those people, about 1 in 7, started to develop problems with opioid abuse or dependency. And then about a fourth of those people ended up in the emergency room with acute medical conditions related to opioid overdose. And then a smaller number of those people ended up into either treatment for opioid substance use disorder or overall mortality. We understand, therefore, that the 115 Americans who die every day are really the tip of the iceberg, and the problem lies fundamentally at the base of that, where we can do things that are better for care and do things that reduce risk and still take care of our patients. When I'm thinking about the different aspects of what we're doing to reduce this epidemic, I like to think of this diagram. When I think of that one person who dies up at the top of that, that's kind of our naloxone efforts. The naloxone is something that we're giving to reverse acute respiratory failure caused by acute overdose. If we can save a life on an individual who has a problem of opioid abuse or misuse, then we can reduce that mortality risk, but we're still going to have to do something to prevent that from occurring again. In the middle of that iceberg, those people who are abusing the medications are physically dependent, that's where we like to think that the PDMP can come into play, where we can understand if individuals who are showing up with risky behaviors, red flag states in the PDMP, then we're understanding those people as being somebody who has developed an opioid use disorder, and we need to intervene at that stage in order to reduce the risk of them going on to become a mortality at the top of the iceberg, if you will. And then what I think is maybe the most important effort and the way we can most fundamentally alter what's going on is at the base of this, those 825 non-medical users, and even below that, the far greater number of medical users. And it's through the use of the pain guidance document we're trying to affect the base of this problem. So therefore, we can really reach people before they develop these acute problems that require either the emergency room, substance use treatment, or naloxone in order to prevent death or significant problems. So we had that in mind when we put the committee together for the pain guidance document, and we really wanted to use the document as a way to help teach clinicians risk stratification, teach clinicians how to identify treatments that were not well supported in the literature versus those that were, and also to use kind of a common set of data points in order to help people communicate with one another, both clinician to patient, clinician to clinician, one healthcare system to another, in order to use a common language to understand the risk and benefit ratio of various kinds of treatment in various clinical scenarios in which opioids may or may not be appropriate or considered. Let's go to the next slide. So when we get to the acute versus chronic pain guidance, we really have to understand that these are completely different sets of risks, different sets of conditions, and different sets of problems. It's not one size fits all. The risks associated with opioids is always in the backdrop of the relative benefit. So we have to really take an approach that takes into account the disease state as well as the particular patient and what they're suffering from with this. When we're teaching this and when we sat down as a committee, we really wanted to put into our mind this concept of acute pain versus chronic pain and versus palliative care or cancer pain. We understand in the medical world that when you have an acute pain injury situation, whether it be trauma or surgical or something significant with respect to nociceptive tissue damage, in the middle there, that's the Cartesian model of pain. That's a way to say that acute pain is almost always opioid responsive. A patient will get better with a fracture or postoperative care with respect to opioids. So they're very often indicated. They're our front line of treatment in an acute pain setting, and we need to assess the risk and make sure we're prescribing in a way that reduces the risk and reduces the ongoing use of medications when they become less effective over time. And we also want to remember that cancer pain is essentially a longer-term, potentially longer-term acute pain situation. It's very often nociceptive, and as a nociceptive pain situation, it is more likely to be opioid responsive, and therefore we consider cancer pain uniquely with respect to the risks of treatment. That is a way to say that we're more likely to use opioids, and we need to use opioids in a way that maintains good safety, therapeutic efficacy, but understanding that we'll accept increased risk in order to get long-term palliative care for patients suffering from pain. The chronic pain is the situation where we really need to help clinicians understand how treatment with opioids is uniquely risky and potentially uniquely problematic. Chronic pain with respect to opioid responsiveness is a very challenging subject. A lot of emerging literature shows us that essentially opioids with chronic pain are very less commonly effective. They're not as effective as many public members believe, and in many cases, chronic pain is opioid non-responsive. So it's not a matter of tolerance, or it's not a matter of just increasing the dose. Dose escalation in chronic pain is very often ineffective, and we really needed to take the time in the document, we believed, to explain to clinicians why chronic pain it may be opioid non-responsive, how to identify the lack of responsiveness, and how to help clinicians explain to patients why we want to go in a more important or safer direction. So a large part of our document was explaining the whys and the hows of that particular problem. Next slide, please. So the acute pain concept, we understood acute pain does account for mortality and morbidity and mortality with respect to opioids. Very often this is something found for reasons that include overdosing acutely in opioid-naive types of patients, patients not understanding how to use the medications appropriately, maybe where clinicians are doing something such as one-size-fits-all, or they're using long-acting opioids in opioid-naive patients, all of these problematic behaviors that we need to try to reduce for patients. What our document essentially explained in this is that we want to use appropriate doses of opioids for the shortest appropriate period of time. We don't want to give high numbers of opioids so they sit around in medicine cabinets for long periods of time. Our document essentially said that many opioids for acute pain are only necessary for 2 to 3 days and rarely more than a week unless there's something more complex with respect to the tissue damage or in severe cases. And so we're trying to give clinicians understanding and the cover, if you will, to use opioids appropriately up front and then discontinue them at the appropriate time. We introduced a lot of information in this overly busy slide, and I want to point out that these screenshots are really directly from our pain guidance document. And what we're doing with this is we're trying to say to the clinician, use the opioids to abruptly reduce pain in the acute tissue recovery period, and then as the tissue healing occurs, it's time to move away from the opioids sooner rather than later in order to reduce the risk of developing problems, which, as most of us know, can occur very easily within the confines of the first 30 days, certainly by the time a second prescription is considered very often. So what we want to do with this is give them the idea that there are other ways to use different types of adjuvant agents that are important, how to introduce those, how and when to consider those other agents, and also how to communicate, importantly, how to communicate with the patient when other agents and other techniques are going to be more effective. And this is, as we know, important in healing as well. It's not just good medicine with respect to reducing opioid use and the risk of overdose. It's good medicine in terms of getting people up on their feet to allow for recovery, because in the acute pain situation, recovery of the initial tissue damage is one of the key indicators that says we can reduce the treatment for pain because it's no longer necessary. So let's move on to the next chronic pain concepts. Chronic pain concepts, as our document really goes into great detail to describe, chronic pain is not acute pain over a longer period of time. Chronic pain is different physiology. It's neurobiologically different than acute pain. It very often represents an exaggerated or augmented nervous system response to initial nociceptive pain. We want to explain that in the documents, and we want to teach clinicians how to explain that to their patients, how to communicate the concept that with respect to opioids with chronic pain, more is very often not better, and in fact, chronic pain is very often completely opioid non-responsive. When patients understand that, then they can understand why it's compassionate for a physician to use other ways of treatment for chronic pain. It's not a matter of disrespecting or minimizing the experience of pain. It's a matter of going in a more therapeutic benefit direction for the patient. So in our chronic pain concepts, we're talking about the different reasons and the different types of treatments to use rather than just the opioids. We're talking about how you measure the therapeutic usefulness. We introduced the concept that functionality is of key importance. If a patient isn't improving functionally with the use of opioids for chronic pain, then it's very likely that that's not going to be something that's in their best interest, or it's an opioid non-responsive situation. We talk about standardizing ways to measure that functionality, both up front with the patient and in an ongoing fashion so that we can understand the usefulness of the treatment. And we also really took pains in the document to describe for the clinicians and ultimately the patients as well that the subjective experience of pain is not as good a determinant in terms of efficacy of the opioids. It's impossible for a patient to understand sometimes why it is that we're going in a different direction when they genuinely feel that the opioids have been helpful for them. And so we want to put forth the literature, put forth the data sets that clinicians can use to demonstrate whether or not somebody's doing well with these opioids. We're also wanting to use this document to explain the different types of things that are available and when to consider them and when to reconsider the different options that are available to improve chronic pain. And the last thing that we really wanted to take pains to develop in the document and to teach clinicians how to use is how to identify increasingly risky behavior. What aberrant behavior means with respect to the development of opioid non-responsiveness or opioid use disorder, which is essentially the patient is losing the ability to control the use of the medications. That's the deflection point with respect to appropriate use and inappropriate use and developing future problems with that. So our document, I think we really went into great detail on that. We really spent a lot of time as a number of different clinicians from different areas. We went through the process of what are things that we believe we can stand on with respect to the literature, what are the metrics that are the best to use and to help clinicians use in order to standardize the measurements that we're all taking across various providers so that we have a common language to assess the benefit and, more importantly, the risk of these types of medications and or their treatments. So with the next slide, of course, there's lots of different situations rather than just acute pain or chronic pain where we have special considerations that we had to take into account. We had a number of different providers from various different areas, and we really tried to anticipate all the different clinical scenarios when these types of medications might be used, and when we can and how we can identify the appropriate use versus inappropriate use. So with our patient populations, we have different chapters in our document for these various patient populations. One of the document's chapters that we believe was most important was the concept of chronic pain in the face of trauma, that is PTSD, psychological trauma, and chronic pain. It's important for clinicians to develop a greater in-depth understanding of the role that the symptom of chronic pain can play with respect to individuals who have experienced other types of traumas. Many times a patient who has experienced something that's completely unrelated to physical tissue damage is experiencing very valid chronic pain complaints as a specific symptom of a traumatic condition that pre-existed this. So it's easier for clinicians to communicate with patients why opioids may not be in their best interest, why they may be uniquely risky in an individual with an affective comorbidity, when we're describing what it is to have the physical experience of pain with respect to psychological trauma that precedes it. When we get comfortable as clinicians in understanding that it's not just a subjective pain that equals tissue damage, but it may indicate problems with respect to these conditions, then we can do a much better job of compassionately communicating that with patients. One of the things that we're very proud of is that not only did we talk about this concept, but we also went into great pains into helping clinicians develop strategies, even specific dialogues to go into ways that they can communicate that with the patient so that the patient understands that we genuinely care about the subjective experience of pain, but that does not mean that we're going to want to expose them to the risky medications that have these very low likelihood of providing benefit and increasing problems with respect to adverse effects. Also, with respect to chronic pain in children and adolescents, that's also a unique situation. Not only are adolescents very different with respect to how they metabolize these agents, but it's very hard in some situations to get adequate communication and understanding of the experience of pain. And then also the concept of how do adolescents respond to the concepts of trauma, PTSD, or affective comorbidities with respect to this subjective experience of pain. So we were very careful to want to be sure that we're treating pain, but we're also trying to dissociate the concept of using these medications with the idea of treating pain. And so our chapters in this regard are attempting to do that specifically. Please, next slide. Also, with respect to the elderly and individuals with dementia, this is going to be something that we face statistically, epidemiologically at greater frequency going forward. So we really wanted to have a chapter that described how these individuals have unique risks with respect to the higher likelihood that they may develop adverse effects, the other medical conditions that this can play into with respect to developing morbidity and mortality, and also the concept that despite the fact that we understand that individuals as they age have an increased risk of developing nociceptive pain that may be opioid responsive, they're also at increasing risk of developing these other kinds of conditions, which are chronic pain that is non-opioid responsive. So it's important to understand that as individuals age, it's not just tissue damage that increases, that's not just nociceptive pain that increases. So therefore, chronic pain situations that develop even in an individual that's maybe experiencing degenerative arthritis and what have you, it may not be opioid responsive, and it also may not be opioid responsive at a level that makes it acceptably safe to use because of the increased risk of developing adverse effects because of the other comorbidities. We described that in our chapter, and then also we had a chapter on pregnancy, and in pregnancy, the unique physiologic changes of this. Obvious, we have two patients in any pregnant patient, the volume of distribution, the role that the use of opioids can play with respect to developing problems. So we had a chapter that included recommendations regarding the opioid use in pregnancy. Next slide, please. Okay. So with respect to differentiating pain treatment recommendations, we really wanted to spend the time to help clinicians understand what to do with respect to legacy patients. That's one of the recommendations in the CDC, is to understand that there's a wide variety of patients who have been prescribed these medications in the past, and now they are developing either a lack of efficacy, they've had dose escalation with lack of efficacy, or they're developing tolerance. But these patients didn't initially start out with this as their idea for treatment of pain. As medicine has moved forward, we've understood that opioids are less helpful than we thought they were at one point, and yet you have these patients who have been taking these medications for a long period of time. So how do we communicate to as clinicians, both compassionately and also effectively, in order to change the direction? What kinds of language can we use to make sure the patient understands that we're still trying to be on their side to improve their chronic pain, despite the fact that we're recommending perhaps removing or tapering away from a medication that they believe to be what's effective for them? Motivational interviewing we discuss all the different kinds of ways that communication can occur so that patients understand that it is possible to first effectively treat chronic pain and also to go in a direction different from the opioid use that they've experienced in the past. So then we have to go into tapering. I think one of the areas that really we felt it was important to communicate in our document that if you're the person who has been prescribing for a clinician, or as a clinician for a patient, and you have the patient relationship with the patient, you've developed the trust over the care with this patient, that you are uniquely in the position to reduce the risk for that patient. We see many different times where a clinician feels stuck. They know that the prescription opioids aren't doing what they thought they would. The patient is maybe developing problematic behaviors or use patterns, but they don't know what to do. So very often what they do is they hurt the relationship with the patient by making the patient feel scolded or feel like they're part of the problem rather than they have a problem, and they very often tend to turf this patient to a different location, and that is a risky type of thing to do. So we wanted clinicians to understand that if you have been prescribing for a patient, you can be the person who can taper these opioids with the patient, or at least participate with the patient in the tapering of these medications if you're referring on to a specialist provider. But in order to get the best care, we wanted any clinician who was prescribing medications to understand not only when it was a good idea to do so, but when it was a bad idea to do so, and when you had made the determination that it was no longer in the patient's best interest, how you taper away from these opioids in a way that's most likely to be successful and yet preserve the relationship with the patient, the dignity and the understanding on the part of the patient that you're doing what's in their best interest. So other resources that we want people to consider, as I alluded to earlier, it's a collection of efforts that are going to be very important in order to get this problem reversed on the part of the patients. And each part of this process has a unique role in helping reduce the risk and improve patient care. One of the ones that we're getting used to in the state of Nebraska is our prescription drug monitoring program. We find it to be very effective at identifying which patients are taking which medications and which combinations of medications are problematic, as well as patients who may be getting medications differently than they're representing to the clinician on the visit. This is something that is advancing. We're making better efforts with this going forward. We have a lot of exciting things with this moving forward. Obviously, medication disposal is something that we want to continue to work with. Many areas of the country, there are more prescriptions for opioids than citizens, and so there's a lot of medications that are laying around in medicine cabinets, extra medications, and we need to help people know how to get rid of those medications when necessary. Another thing that's very important is the medication-assisted treatment programs. The evidence is out there, and it's compelling that if individuals develop opioid use disorder, medication-assisted treatment is the most effective way to provide safe care to reduce the use of opioids in a long-term fashion and reduce mortality. We need to make sure that we are able to get patients who develop problems compassionate care, and we need to continue to work to get more programs available, more clinicians comfortable with the use of the treatments that medication-assisted treatment provides. And of course, lastly, our naloxone efforts. Naloxone is a medication that, as we know, is a lifesaver in an individual who has developed opioid toxicity and overdose. And this is we have really good programs that are now available in our state to make naloxone available and encourage the use and or the availability of naloxone in an individual who is potentially at risk of a life-threatening morbidity. So those are our efforts in the state of Nebraska. And with that, I'll answer any questions.
Excuse me. Thank you so much, Dr. Massey and Amy, for being here, too. That was excellent. We want to use our remaining time for questions for either Amy or Dr. Massey. You can enter your questions, or you can press *6 to unmute yourself and ask your question, and then *6 again to remute your line. So, Jamie, do we have anyone yet? Any questions yet?
Not that I see yet, Tammy.
Okay, well, again, it's *6. We'll come back to the questions. We want to invite you to visit the Great Plains website at greatplainsquin.org again for resources pertaining to medication safety and opioids, as well as other initiatives being led by Great Plains. We want to be sure to join our Learning in Action Network if you're not currently a member to receive notifications on future educational offerings provided by Great Plains, such as these Medication Safety Land events. The National Institute for Health, for one, said last week that it's doubling funding with an aim to speed up its seeking of solutions to address this crisis, which kills more than 100 Americans each day. And the U.S. Surgeon General also issued an advisory Thursday, the first from that office since 2005, urging family and friends to carry the overdose-reversing drug naloxone. Again, just as Dr. Massey said, every day more than 115 Americans die for overdosing on opioids. We have a question. Yes?
Yes.
Okay.
We have a question from Jennifer. Are providers being limited on the number of tabs that can be prescribed or dispensed?
This is Amy, and I'd be happy to answer that. So currently, the state of Nebraska does not have a limit through statute on the number of pills that can be prescribed. However, recently, as recent as last week, LB 931 did pass, which includes a 7-day limit when prescribing opioids for minors, which in the state of Nebraska is 18 years and younger. And so that would be a 7-day limit for those adolescents. Also, Medicaid does have dosing limits or pill limits. Currently, their limits are 150 doses per patient per month. I know that might seem high to you, but there was a lot of information that was configured into that limitation being set. But Medicaid does have the 150 dose or pill limit per patient.
Thank you, Amy. I see there's another question, Paula.
Yes, this is from Barbara. Do you have information of when EPCS is likely to be required in Nebraska?
I'm not sure we know what EPCS is. If somebody could, Barbara, if you could chat that in, EPCS. Jamie, do we have any questions online while Barbara is?
I don't see any others
Nobody?
in the chat.
Okay.
Reminder to everyone on the phone that please press *6 if you wish to ask a question via...
Hello, I have a question.
Yes.
Yes, what do you do for these patients that want to go through treatment, but their insurance won't pay for it? We had one that wanted to go through treatment. She was very ready, and her insurance told her she was not on enough medication, and she had been on opioids for years, and they would not pay for it. We had another patient that self-admitted, and he was there for 2 days, and his insurance said that they wouldn't pay for more than 2 days, and they kicked him out and sent him to sober living. So that is our extreme frustration, because we've had several patients who, come to us, been on opioids for years, but then their insurance won't pay for or any other alternative treatment, such as massage therapy, yada, yada, yada. So what about that? Because that is really a problem.
Yeah, that's a great question. And our approach, it's unquestionable that the need for those kinds of services outweighs the availability. You have to remember we're in Nebraska, and there are wide geographic distributions of patients with this problem, and there is no treatment available in the nearby distribution. We really do have an access to care issue. But our document, really what we're working on in our document, it's a tool for clinicians to understand that it is more possible to treat these kinds of patients in an outpatient basis or within their own clinic if they can just develop a little bit more understanding and or how to taper, how to get into those other kinds of programs, the waivered programs and what have you, so that we can solve this as clinicians without having to create brand new problems. We're basically developing new skill sets as clinicians. It's certainly something that I would agree with, that medication-assisted treatment programs aren't available as much as they need to be, especially given the enormity of the problem. But the best way, I think the most practical way, is for us as clinicians to develop the skill set and more than that, maybe the comfort to understand how we can help patients get away. I'm not an addiction specialist, but I do have my X waiver, and I have many, many patients that I've been able to wean off of opioids who come to me for chronic pain treatment. And when we get them off of opioids, they're almost invariably more comfortable when they've developed opioid use disorder, because as we all know, it's the opioid use disorder that drives the physical expression of pain in that situation. So once we get
Go ahead.
So once we get clinicians comfortable with that, then we really have a very powerful tool at our disposal, and we aren't going to be quite as dependent on getting patients the care with their third-party payers for inpatient-type treatments.
And how do I download this set of slides that you shared so that I can give that to my provider?
Well, we'll show you that, but I'd also really encourage you to download our whole document, because the document is one you really want. And I'll give you that to Amy. She'll give you the best answer, I think.
That'd be fantastic.
I'll work with Tammy to make sure you get the slides, but I also want to just remind folks, the Division of Behavioral Health, so I'm with the Division of Public Health, but we collaborate very closely with the Division of Behavioral Health here in the state of Nebraska, and they have the State Targeted Response to Opioid Crisis Grant. They're utilizing some of that funding to train providers to get their X waiver, their DEA-X, so that we can develop a more substantial cross-section of treatment providers across the state of Nebraska. We do have an access issue to some extent, and so that is something that we're really trying to promote and help DBH by expanding their access. So know that that's also going on. I would echo what Dr. Massey said. I would get that document downloaded. It's a pretty easy read, but I would maybe prepare that as you go and approach your clinician about this situation. Also, through the Division of Behavioral Health, the regional behavioral health locations, there are 6 regions across the state, they do provide access to treatment for those who are underinsured or uninsured. So if there's an insurance issue, I would encourage to seek out, and I don't know if this particular individual would qualify because it seems like they already have a health insurance company, but know that that's also an opportunity. And I also want to say on a national level, there's a lot of work being done by a lot of national organizations to look at our third-party payers and the lack of the ability to pay for treatment as well as non-opioid treatment modalities, such as the massage therapy, chiropractic, acupuncture, and so on. So I know there is a movement in that direction as well, so not just for MAT services, but also the other non-opioid treatment modalities.
And the other part of your question that I think is important when you say that things like massage therapy and what have you haven't been paid for, at least in my experience, if you have somebody with chronic pain who also has developed opioid use disorder, you really have to first and foremost, in a headlong and direct, compassionate way with the patient, you have to address that issue up front, because until we like to say that it's never possible to successfully treat chronic pain in the face of unrecognized addiction. So the massage therapy and those types of things that are helpful in other situations, if you've got an individual whose pain is being driven by the opioid use disorder itself, you're not going to get relief no matter what kind of money you spend until you get them away from the problem in the first place. And having that communication with clinicians is a challenge, and as clinicians we need to internalize that message so that we're not wasting the fewer dollars that we have at times in treatment that is maybe not going to be effective until we do what's most necessary.
Makes sense.
Now, if we could go back, we have just a couple minutes left, and that question on do you have information of when EPCS is likely to be required, and thank you, Kevin and Barbara, it's electronic prescribing of controlled substances. So
this is Amy. I'm happy to respond to that, and I can tell you at this time there hasn't really been any discussion on a state level with state senators. That would take statute change, or it would take a change with our Board of Health rules and regulations through the Department of Health and Human Services for that to happen. So to my knowledge, I don't believe that there's any movement in that direction.
there was a statement here from Laura, just in their clinic, they choose not to prescribe controlled substances electronically because it holds the patients more accountable or liable to come to their appointments every 2 months.
Absolutely.
So, back to the slide deck question, and we definitely think the Nebraska Pain Management Guidance, this site actually has YouTube video, all the PDMP information. It's got everything. It's including the Nebraska Pain Management Guidance document. So if you go to this site that Paula has put in chat, you can find everything. And let's see, was there another question out there? We have 1 minute.
There are no further questions in chat at this time.
Okay, well, again, I want to thank Dr. Massey and Amy. We do ask all attendees to complete the evaluation form when sent for today's event to offer feedback. The recording will be posted, and we will have the slides. I did notice the slides were not accessible yesterday on our website yet, and Paula, if you want to put that in the chat, greatplainsquin.org, and it's under events, and it'll be past events, and we'll get the slides there so you can access those and the recording within 7 to 10 business days. Feel free to contact Great Plains Quinn Medication Safety Leads. You can see right here with any questions you might have, and really we thank you again for participating today, and we hope that you found the information valuable and applicable. So thank you, everybody. Have a great day.